Hi everyone, my name is Benita Aroda. I'm an endocrinologist at Brigham and Women's Hospital and a clinical trialist and associate professor for Harvard Medical School. Really pleased to have Drs. McDonnell and Drs. Plutzky, and I'll have you two introduce yourselves. Marie.
Hello, hi Benita. Nice to be with you today. I'm Marie McDonnell, and I'm chief of the diabetes section in the Division of Endocrinology, Diabetes, and Hypertension here at Brigham and Women's Hospital and Harvard Medical School, and director of the Clinical Diabetes Program.
Hi, I'm Jorge Plutzky. I'm the director of preventive cardiology at the Brigham and Women's Hospital, and have a longstanding interest in the intersection between diabetes metabolism and cardiovascular disease. And I have Vanita and Marie as invaluable colleagues, consultants, and teachers as we wrestle with these interesting, exciting opportunities that new data is providing us.
Wonderful. So I'll kick off then, Jorge, on the comment that you just made on teachers. So we got a lot of comments after the lecture at the Cardiometabolic Health Congress. And I want to ask you, Marie and Jorge, both, you both have educated so many trainees, so many providers, colleagues, patients. What do you think are the key kind of pearls of education when introducing people, including our own colleagues and clinicians, to the GLP-1 receptor agonist class? Marie, from your perspective.
Yeah, sure. And my perspective really is from the endocrinologist perspective, perhaps. And I want to echo what Jorge mentioned, that we learn from each other. And I actually really, I almost physically put on the cardiologist hat when I see patients to make sure I'm not missing the opportunity with some of this drug class specifically. But I would say that the way I teach this and the pearl is that the GLP-1 receptor agonist is so pleiotropic and so potent as a glucose lowering agent and a weight sparing or weight losing agent, that it actually has benefits sort of beyond the classical drug class, and that needs to be considered when we counsel patients, because potentially the burden, including the cost and the side effect profile, it has to be balanced with that pleiotropic effect and benefits. But we have to do that really well. So the pearl is to really understand the far-reaching benefit of the drug class.
And Jorge, as a cardiologist, how can you share with us kind of your learning curve of incorporating this class within cardiology care, not just for yourself, but for your trainees and for your own colleagues?
Yes, it's a critical issue, because it's one thing for us to chase advances and look to improve outcomes, but it's another thing that now I think we embrace more fully, of how do you implement those advances once they've been found. And we know from other progress that's been made is that that's slow and too slow. And so I love the notion of implementation science and the focus on how do we accelerate that process, because it just shouldn't be that way. And we've spent a lot of time, and we spent a lot of time together, the three of us, thinking about those barriers and how do you overcome them. I think a lot of it has to do with fear and sort of concern of harm. I think another component for cardiologists, and now speaking mostly about my colleagues, is the sense that that these are diabetes drugs and they don't know how to handle them, and they're worried about adverse events and the follow-up. We really stress that these are cardiovascular endpoints we're talking about, and just like we wouldn't ignore a new stent with much better outcomes, or a new treatment for heart failure that has an impact on outcomes, or a new treatment for the risk of heart attack or stroke, that we can't ignore these just because they started out as diabetes medicines. It's less of an issue for the trainees who are coming, are closer to their residency, and they sort of really are already there. I think what we really have to do is catch up with the rank and file cardiologists and supporting them and really encouraging them just to get their experience that these drugs are um, quite safe and well tolerated, and that when you are concerned about a particular patient that might be more of a risk for a side effect, then get help and refer that one. But for the vast majority of patients, these agents can be used and used quite safely. And so I think really thinking about how to accelerate that uptake and use is critical. And I think it probably is going to end up taking a multi-pronged approach, and not just CME, but other, innovative strategies.
I think it's such a good point. When we're in clinic, I can't see myself prescribing quote unquote cardiology drugs, and the cardiologists can't see themselves prescribing diabetes drugs. In my role on the guidelines and standards of care recommendations for the ADA and then the international consensus recommendations, we came up with the terminology cardioprotective glucose lowering agents, because that's really what they are. And so, you know what? They belong to every provider that sees the patient, primary care, nephrology, cardiology, endocrinology, as a class of cardioprotective glucose lowering agents.
Yes.
So Marie, let me go back to you. I've just now hinted on the guidelines. Since your lecture, the updated ADA EASD consensus was released, and updating the standards of care for the ADA in the 2023 standards as well. Can you share kind of your impressions of the updated guidance?
Yeah, thanks, Vanita. I think what I was able to sort of incorporate a little bit of that, because we had some early output from the EASD. But what I like about the updated guidance is that they're trying to simplify the message and add more clear value and importance to weight management, which I think has always been there in the guidelines, but hasn't really been emphasized as something really important for patients, as important, I should say, as glucose lowering. And in fact, they should be considered a package deal. It's been implied, but I think this goes along with treating obesity as a disease. And I think that the ADA and the EASD, that collaboration, they're putting that forward in the guidelines as a unified goal for glucose lowering and weight management. And then sort of on the other side of the same coin, the cardio and renal protection. And if we communicate to patients that way, in my practice, I find that they really understand why I would recommend a drug class that, as I mentioned, might feel initially burdensome to the patient or to the clinician, which is resolved quickly in our experience. Patients, as Jorge mentioned, they tolerate the drug class very well if we give them enough guidance. So I think the idea that we can communicate to patients, we're trying to help you lose weight, control your glucose, and protect your organs, that message is not hard to put out there. And they're helping, I think, our colleagues at the top there in these the guideline panels are really helping us with that. And I appreciate that, because as you know, Vanita, and Jorge, the guidelines have kind of been algorithmic and complex over the years, to the point where folks have expressed frustration at the lack of a clear blueprint in some of the guidance documents, and that's changing now, and it's really refreshing to see.
Thanks for that input, Marie. I can share from having been part of the committee that drafted this, is really the goal was to simplify it and keep the patient at the center. So who is in front of you, what is their care goal, and how can we support it? So, talking about organ protection at the one hand and glucose lowering at the other as your two key goals, with weight management being an instrument that helps you achieve both. So let me ask you, Jorge, then when you distill the guidelines to patient care, do you focus on one aspect or the other, or do you talk about it all with patients?
Well, I think in the same way that we have to simplify things for providers, I think we also have to simplify things for patients. it's interesting that physicians really do play a very important role in motivating patients to go on to more therapy because they can have the perspective on the impact it can have. I think there's a fundamental divide about when we're talking to a patient who's already had an intervention, certainly bypass surgery, but also stenting of their engagement around the notion of we don't want to have to do that again, and you have a systemic illness that's going to progress, and that the stenting and the bypass didn't solve the reason why you have it, and we have to push on to other therapies. It's a little bit more challenging when it's primary prevention where someone hasn't had an event, and we don't see enough of those patients. And I think some of the tip of the spear opportunities there for cardiologists with that they certainly exist. We see them in the lipid clinic because they're referred for hypertriglyceridemia, or the finding of coronary calcification, or should I look more? But many of my cardiology colleagues are not seeing primary prevention. The other one that's really interesting and quite relevant in terms of GLP1-RAs and weight loss are our EP colleagues and general cardiologists who are seeing atrial fibrillation. And the data, as we had a chance to discuss in the meeting, for the impact on recurrent atrial fibrillation after ablation or cardioversion with meds or electricity is really very impressive. And so there's an opportunity to be seeing a patient, if you're a general cardiologist who's overweight, maybe has prediabetes, doesn't have frank diabetes, or does have frank diabetes, and you've got an amount of atrial fibrillation, is to be the one to say, you know what, I really want to push on in terms of tackling weight with the GLP-1 because of the impact it could have on your staying and sinus rhythm. And that can be very, motivating. So I think it is, probably everything, but starting off with very immediate issues about what's the most pressing concern you have with the patient, and then implementing and then moving on to additional opportunities for more, therapies, I think is the way to go. Starting small, focused, getting something on board, letting a patient see how much better they're doing, and then pushing on.
Thank you, Jorge. So now this brings me to a very practical question that I'll ask both of you. We now have both GLP-1 receptor agonists and SGLT2 inhibitors established as cardioprotective glucose-lowering agents in people with established or high risk of cardiovascular disease. How do you make way for these agents within the regimen? So from a cardiologist perspective, Jorge, you see someone is on multiple glucose-lowering agents, multiple cardioprotective agents. How do you make way for the new class?
Yeah, so it comes back a little bit to where, you hear such a drumbeat about use these drugs. And I know a lot of my colleagues feel overwhelmed by them. And so I think rather than are looking for 100% use, I think it can be a relief to simply say, look, here are the straightforward, non-complicated cases where this drug is indicated. And if you're looking at someone who's on 2 or 3 agents and insulin, and their A1C is 6.6, and they have, occasional symptoms of hypoglycemia, I think it's an easy place to say, hey, let's get a professional, as opposed to an amateur. But, very often in clinic, we're seeing people who've had cardiovascular events, had stenting, have diabetes, or on 1 or 2 agents, including an SU, and their A1C is 8. And it's like, you know what, that's going to be fine. Implementing and then following up. So in terms of making room, I'm not sure that we always have to. I think the one time where we're cautious about that is with SGLT2 inhibitors and patient who's on an aggressive diuretic regimen, of maybe having the diuretic and avoiding getting into issues. But for the GLP-1s, I think we're usually just adding them on, and also using them in obese patients who don't yet have diabetes for their obesity indication, even while we wait for clinical trial results on cardiovascular benefit in people who don't have diabetes. They do have an obesity indication, and very appealing to patients, when approached that way. So I actually have advocated before and, raised you both, and I think it's something still worth doing. It could be perhaps a real role in the literature of providing guidance on when to not use these agents, so people can say, okay, well, I'm okay in these kinds of patients and I'm not going to run into trouble. And so, which is bundled in with the idea that, well, I need to make room for these drugs because someone's not going to tolerate them. Of course, cost is always an issue too, in terms of making room.
And Marie, from a very practical endocrinologist perspective, what advice do you give to your colleagues, and how do you, quote unquote, make room for these agents within the regimen?
Yeah, it's such a great question, and there's almost always room for the GLP-1. I think it's important to tailor to the patient, but it comes back to the individual patient. So understanding what their experience has been with their current regimen is really important, and sometimes you need to spend extra time on that. For example, metformin, people will live with uncomfortable loose stools for years on that medication. What a wonderful medication metformin is as a glucose lowering agent. But, suffering is not good. And I think sometimes one of my favorite things to do is to replace metformin with a GLP-1 in patients who are struggling with chronic side effects. There's some good information about metformin-induced GI upset that it seems to be patient specific. Maybe we could learn a little bit more about how to predict that in the individual patient. Maybe there's a genomics opportunity there, but or pharmacogenomics. But it doesn't really resolve in an individual patient once it's uncovered. So that's an example. The other example of making the case for the patient in a simple way when they're thinking about glucose control is replacing potentially another drug class like a sulfonylurea, that again, an excellent glucose lowering agent that has problems around weight gain and hypoglycemia. And you need to replace that medication with a potent drug. It's very difficult, if not nearly impossible, to achieve the same level of glucose control if you go from a sulfonylurea to, say, a DPP-4 inhibitor. And hence yet we still see that because it's a simple pill-to-pill exchange. But what we need to think about is potency, so the patients don't feel like they're failing. And the GLP-1 slides right in there as a very potent agent that will promote weight loss that the patient's probably been missing out on for years, and will actually do the job. And so then, of course, we can move on, as Jorge mentioned, to maybe the secondary goal in that particular patient, which might be cardiovascular risk reduction. So
wonderful. So this brings us to the end. I just want to say thank you to you both, Marie and Jorge, for taking us through the practical, the theoretical, and really always kind of reminding all of us to keep the patient at the center. Realize that we're living in exciting times with novel tools that can address the cardiovascular risk, the metabolic risk, body weight, and glucose in a meaningful way. And there's still a lot to learn and a lot to share. So thank you.
Great. Thank you. Enjoyed it.
Thank you so much.